And good afternoon. I'm Dr. Ara Deuk-Majan, CEO and founder of the Deuk Spine Institute. I'm a neurosurgeon. We're getting ready to start treating a patient who traveled from California. She has 5 herniated discs in her thoracic spine. 2 of them she's chosen to operate on today. We're going to be doing the Deuk laser disc repair. It's an endoscopic surgery designed to treat pain from an annular tear, herniated disc. We've chosen to treat T5-T6 and T7-T8. T5-T6, T7-T8, right side, because that's the side they're on. We're going to start by numbing up the skin a little bit. Our patient is laying on her belly. She's in twilight anesthesia right now. And we're going to go ahead and get started. If you have questions, feel free to ask them. First step is going to be a little bit of num-num. The first step is going to be to position her, prep and drape her, which we've done. The second step is going to be to place our spinal needle from here, the operating room, down to the target, which is your annular tear, transforaminal annular tear at T5-T6 and T7-T8. All right, so we've already done the positioning, the prepping and draping. Now we're going to place our spinal needle into the T5-T6 disc, and then we'll do the T7-T8 later. If you have questions, go ahead and ask.
No current questions, but we do have a comment from Canes25 on YouTube.
Welcome back.
And they said, got my popcorn out, getting ready to watch Thoracic Park.
There we go. Thank you. Thoracic Park, I love it. All right, so I'm just going to talk to myself and let you guys get into my mind. All right, we're looking at the x-ray. Show us T1, Jordan. I would go just a slight bit higher. There we go. You can see T1 on the right. Yes, there's the pedicle of T1. Let's count down. 2, 3, 4, 5, 6. That's right, and then 7 below. So we're doing 5-6. So I'm in good position so far with my entry. I'm at level with 5-6. Is she comfy? Shot. So I'm going to use my AP view, and I'm going to switch over to my lateral view. Go ahead. I'm sorry, what is it? Yeah, let's keep an eye on the arms. As we swing our fluoro C-arm around, we want to make sure we're not banging on our elbows or arms. So far, everything looks good. 1, 2, 3, 4, 5, 6. All right. So that looks like 5-6 right there. Look at that thing. It's pretty collapsed. Definitely spondylitic. You guys see it? Yep, right there. There's actually a little, what is that, an EKG lead on the skin right there? Yes, sir. Yeah. All right, so let's make our way down. There's the old rib shot. Need to be a little bit higher. Shot. Now, I think we're off on our WAG a little bit. Let's get our WAG up. WAG is where we move the fluoro this way. Kind of move one side that way. And what we're looking at is the pedicle. You can see the pedicle of 6 is not lined up exactly. I think you're still off. Wouldn't you say? I mean, are we? Unless that's the edge of the rib I'm seeing. It's not horrible, Jordan, but I think that's maybe better. I'm happy with that. So we're too low. We need to be a little bit higher in our approach. Shot. Still too low. Shot. A little bit high. Shot. Just lay still. If you can keep her comfortable. I think I'm too medial. I need to come in. Shot. High. Shot. That's nice in terms of a trajectory. I just need to get a little more lateral. Give me an AP. I have a feeling I'm touching her facets. And if I am, I need to be a little more lateral, probably just a few millimeters more lateral. But it's always better to err more medial. If you're going to err lateral or medial, it's better to be more medial. Yep, we're too medial, so we're just up against her facet. That's good though. Back to a lateral view. Kind of touching the facet. Either that or the TP and the rib. You can sort of see the rib head coming in. All right. I may want to start a little higher up, but I'm going to see if I can make this work. Yeah, I may need to be shot a little higher. Lay still, shot. And the space I have is, quite honestly, just a few millimeters of space. I don't have much space. Shot? Shot? Uh-huh. Shot. Very nice. Very nice. Shot. Don't move. She's good. Perfect. Let's get an AP. So we're right at the back of the disc. Now, all we need to do is make sure that's the right disc. So far, all my counting has been that that's 5-6. Perfect, perfect, right there. Look at that. All right, so stay there. Now let's look north just a smidgen. There we go. All right, let's count together. We see 7. Let's go up to C7. Yes, it's got a short little, almost like a, not really a TP, but then you could see the first rib coming in right there. Show us the first rib. There it is, coming in. Show it coming in. Show us the transverse process of T1 on the right. That long finger. Show us the finger. That's called the transverse process of T1, okay? And just underneath it is the rib. See that? So if you follow the TP, transverse process of T1, to the pedicle, you can see the pedicle of T1. It's a circle. So we know that's T1 because it's the first rib. So then we go down to T2, 3, 4, 5, 6. And the disc space between those two pedicles is going to be T5-6. Now let's go down and count from the bottom up. We're going to go down and find T12. We're going to verify with two-factor verification. See, we've been using two-factor verification for many years in spine surgery, long before Apple did. A little further. A little further north. There. All right, a little bit more, just a tiny bit. There it is. All right. So we know the bottom rib. Show us the bottom rib. You're going to have to come south just a little bit. Shot. There we go. So that's the bottom rib. We didn't see any ribs below that. So that's the pedicle of 12, 11, 10, 9, 8, 7, 6, 5. So again, 5, 6, both ways. Top to bottom, bottom to top, using the ribs to count. She has 12 ribs. She has 12 thoracic vertebrae. We are at the proper level, T5-6. I'm confident. Plus, you could see how collapsed the disc is. Show us the collapsed disc there. Can you see this, Henry? Look how thin that disc is.
Yes, we can.
Look at the next disc below. Thicker. That's more normal. It's not totally normal, but it's more normal. So we are at the proper place. Let's go back to a lateral view. It's perfect. So now we're going to enter this disc, and then we're going to place our second needle. I'm going to get both needles placed, and then we're going to start the surgery. I mean, this is technically, we've started the surgery, but we're going to actually start the therapeutic part of the surgery. Shot? I would like to do a discogram. Shot?
You want an evocative discogram?
Yeah, but not right this second. I need her comfortable for another few minutes while I get the next one in. So we are going to do an evocative, just not yet. I'm sort of thinking out loud. All right, so we're doing T5-6. We're skipping 6-7, we're doing 7-8? So we need to move down basically 2 discs. Shot. All right, so there's 5, 6, 6, 7, 7, 8. Very good. Let's go back to a lateral view, please. Let's give her a little num-num. All right. I'm checking my lung fields as well. What I see is good. One of the complications of this kind of surgery is called a pneumothorax, where the actual lung will collapse. And we don't want that happening, but it can happen. And the way you look for that is by looking at the lung fields. So far, so good. All right. So here we go. Shot. It's looking pretty good so far. Shot. How is she? Good? Huh?
She's doing fine. Got a little bit of sedation, trying to...
Shot. AP. We're going to check our AP. So far, it's going quite well. These are going to be a lumbar, I think. Lumbar. Oh, yeah. Looking good. Back to a lateral. 5, 6, 6, 7, 7, 8. Any questions? Let's try to show a little more on my side next time on the AP. Okay, Jordan?
Yes, we have a question from John on LinkedIn.
Yes, John.
They ask,
John?
is the patient alert enough under twilight to respond to questions?
Yes, the patient is. Not this exact second, AP, but they will be shortly. I think we're off on orbit. You see the orbital problem? Show us the orbital problem. Go ahead and show us with an arrow. The back of the vertebral body. Nope, no, no. Go to the back of the vertebral body right there. You see that little, 2 little lines there? Yeah, it's off by about a degree. So let's fix the orbit on the lateral when we go back to the lateral. But right now, give me the AP. I think you're a little too much to your side. That's good. All right, we're closing in on the back of the disc. I like it. And the lung fields look good. Give me a lung field shot on the right. Lung field shot. So you guys see the markings of the lung field shot?
Yes, we do.
All right, so you can see the lung fields go all the way out to the end of the ribs. Show us, Jordan. Those little gray markings are the bronchi, and they're going all the way out to where the ribs are. So there's no pneumothorax, which is really good. Surgeries can have complications. You surgeons have to be always paying attention, you know, while you're doing surgery, making sure you're doing everything you can not to have a complication. All right. Beautiful. All right, let's fix the orbital issue, which we're off on orbit by about 1.5 degrees. Shot. I think that might be worse, yeah. Try. I think that's better. What do you think, Jordan? I think it's still there. Huh? Yeah. I think we've overcorrected there. It seems like we've gone beyond at that point. Maybe we need to go back. I think that might be as good as we're going to get it right there. I see a clear path to the back of the disc. I think we're in good position right now. So I'm going to proceed. Shot. All right, I'm up against the back of the disc. I feel the herniation right now. Shot. Uh-huh. Yeah, we're still off on orbit. I don't know if she's moving a little or what, but at least we're in the right place. Shot. Shot. All right. We're ready, doctor. So at this point, I'll mark her up a little bit. Our needles are in proper position. And we'll hold questions for right now while we get this set up. But you're looking at her back. And she's had, when she came in and saw me yesterday, I verified her level of pain. and we put little paper clips on her back. I said, where do you have your worst pain? Because she's got 5 herniated discs. She wanted to fix 2 out of the 5. We want to pick the 2 that are the worst, and I need her help to do that. So she said right there, right there. Well, that's the worst, and that's going to be your T5-T6 disc, and it's definitely degenerated herniated. Then I said, well, where's next? And she pointed literally right here. She waking up? T7-T8?
How are you doing? You
Okay. How you feeling?
You doing okay?
All right, so somebody asked if she's awake enough to ask questions. Who is that?
That was John from LinkedIn.
John from LinkedIn. All right, so John, what question do you want me to ask her? What's her favorite color?
No response yet, but if there's a question that they'll come up with, I'll shout it out.
All right. I'm going to pull this needle back just a little bit. Are you awake?
How you doing? My friend, can you open your eyes for me?
So let me tell you what we're about to do. We're going to do our evocative discogram. Hey, she's got great anesthesia. She's snoozing.
John asked, how tall is she?
No biometric stuff. No biometric stuff. Try another question. All right, so we're going to do our discogram in a moment. I'm going to try to record what her pain is and make sure that that's where she typically has pain. Then we're going to place our guide wire. We're going to do 1 disc at a time. We're going to then make an incision that's 7 millimeters. We're going to go in and we're going to fix these 2 discs with the laser endoscopically. And then we're going to be done. There's no hardware, no fusion, no metal. It's just simple repair those 2 discs. Are you awake?
Can you open your eyes for me? My friend, can you open your eyes?
John asked, favorite food?
All right, we're just waking her up to get her favorite food. Can you wake up?
Hi, open your eyes. That's great. Open your eyes. We're going to ask you some questions, okay? How are you doing? Can you open your eyes for me? Can you open your eyes? Good. We're going to ask you a question, all right? Can you squeeze my hand here? Good. Okay. Squeezing my hand.
Are you having any pain?
You having any pain anywhere?
Any pain?
You having
It looks
pain
like
anywhere?
she said no.
No.
She nodded her head no. All right, I want her just to be fully awake. So we use propofol to sedate our patients. Propofol is a wonderful drug. It just makes people sleep. It doesn't kill pain. It's not a painkiller. Doesn't do anything for pain. It just puts you to sleep. While you're deeply asleep, though, you're not really consciously registering pain. Are you awake? All right, I heard you. Dr. Deuk here. Everything is fine. You're doing great. We just had to wake you up for this one part of the surgery, okay? All righty. Can you wiggle your toes?
Can you wiggle your toes for me, please? Wiggle your toes. Wiggle your toes. You wiggle them?
Wiggle your toes.
Wiggle them right now. Squeeze my hand. Here. Good. She's squeezing.
Wiggle your toes.
You just squeeze my hand.
Wiggle your toes.
Yeah, she's wiggling.
All right. Are you comfortable?
She said yes.
All right. What's your favorite food?
What's your favorite food? I'm going to ask you a question. What do you like to eat the best? What did you say? Salad?
Salad?
All right.
Is that what you said, salad? All right. Salad. Okay, are you comfortable? Shot? We're getting it. On a scale of 1 to 10, how much pain do you feel?
How much pain do you have? 1 to 10. Give us a number. What number? 10. She just said 10.
Is that where you typically get your pain? Yeah? All right. Is it better now? So we had a 10 out of 10 at T5-6. Is it better? Yes. All right. So you can see the discogram. Show us the discogram, Henry. You can see the dye in the disc at T5-6, and it leaked out the back. Show us how it leaked out the back, Jordan. You can see some of it right there. Beautiful. Yep. It looks like a little nebula. Are you comfy? Yes? She's not asleep yet, right? No. You haven't given her anything? How bad is that on a scale of 1 to 10?
Give us a number.
How high? 10? Is that where you get your back pain?
Yes.
Yes. All right, you did great. We're going to put you to sleep. That pain will be gone. That's wonderful news. Folks, we had to pick 2 discs. We had 5. She picked. I let her pick, by the way. And I always let my patients choose. And I advised her, we did the paper clips with the x-rays. One of them lined up at T4-5-5-6. She chose 5-6. And the other one lined up exactly at T7-T8. She chose T7-T8. We just tested those 2 discs that she chose to have fixed today. They were both 10 out of 10 pain. 10 out of 10, and it was concordant, meaning it's a typical pain. You got that documented? All right, time to move on and get the surgery done. Good news, we know that pain she's had in those areas is going to be gone because we're about to fix it. And we know that it was causing her pain. She told us that. Just giving you some numbing medicine. You're doing great. All right, we're just giving her some numbing medicine. No, not at all. I'm just telling her. All right, folks, we lost about 2 drops of blood this whole surgery so far. I'm going to make a 7mm incision. 7 millimeters. Now, when it comes to thoracic Deuk laser disc repair, there's 2 options. There's the cervical scope, what they call the small scope, and the big scope. And I like to do the big scope. Shot? Because the big scope means we get more herniation out, for sure. I want to do as good a job as we can. Shot? So having the big scope in play means I can get more of the herniation, and I feel like I can do a better job. So I'm using the big scope on patients I can. That means there's enough room between the ribs for the dilator to pass, okay? So now we've got our guide wire in. We're going to bring our dilator down. And Henry, why don't you show our audience how is it that a herniated disc can cause so much pain? What is it about a herniated disc or a bulging disc or a degenerated disc that causes so much pain? What are we dealing with here? That's right. So we have now placed the dilator, and now we're bringing our tube in to do the endoscopic surgery. And Dr. Berndes has really helped us by giving her, making her a little bit deeper in the anesthesia, and I've been able to get this tube in there pretty well. Out comes the dilator, tube stays in. So we're again transforaminal, we're on the side of the spinal cord, and we're right inside that painful disc. I'm going to go in there and use the scope and the laser to repair that damaged disc that's causing so much pain. So you saw the video, it shows you how a herniated disc can be so painful. What it is, it's the inflammation that patients have. Inflammation. There we go. There's the herniation right there. Look how red and inflamed everything is. So that just supports the diagnosis of inflammation. There's the part of the herniation. I want to try to grab some more out. So basically, I'm going to use a combination of laser, releasing, and grabbers to remove all this damaged material that's in the disc that's causing so much inflammation and pain. Now we've actually looked at our outcomes here with the thoracic Deuk laser disc repair procedures. And we have about 20, I think we had 20 patients or 21 patients that we wrote up, and that was peer reviewed and published. We had 99% of their thoracic pain gone permanently. On average, 99%. And that was 13 months after the surgery was over. So we contacted them on average 13 months, and the average amount of pain relief was 99%. That's pretty incredible, especially since not many doctors in the world will even treat painful thoracic herniated discs. Most of them just tell you to go take pain pills or live with it. And we all know pain pills don't work. This is all scar tissue from the actual herniation. That's a herniation right there, that little piece. It's very scarred up. Ah, come on. Any questions from our audience?
Yes, we have a question from Charles on YouTube.
Hi, Charles.
I believe you answered this question beforehand, but I'll ask it anyways. They asked, what were the deciding factors to not repair all defective levels while in the OR, or did I misunderstood that there are other levels?
I think it was money. These surgeries, patients have to pay out of pocket a large amount of money for each disc to get it done, and some people can afford to do more than others can't. So it's really up to the individual patient what they want to have done. Some of them want to just try 1 or 2 discs and see how it goes, you know, and then come back later and get more done. It's not my decision, it's theirs. Now that said, I don't think I would be very comfortable doing 5 herniations in the thoracic in one surgery. So I think I would be okay doing 3. So part of it's patient, part of it's surgeon, and what's safe for the patient. But in this case, I think it was more of a, you know, I don't know exactly why. I don't pressure my patients to do any treatment. That's a personal choice of theirs. They have to decide what they want to do. But I offer them treatments, and then they decide what it is exactly they want to do. So it's a fair question. So you can see this disc is severely degenerated. This process here is old. This is calcium. The stuff we're seeing, the little whitish gold stuff right there, Those are calcium deposits that are literally inside the disc from chronic inflammation. You hear about thoracic disc becoming calcified. That's usually because the amount of inflammation going on is so severe that over time it creates what's called dystrophic calcification, which is where your body will drop and deposit calcium, little spicules of calcium, little calcium growths within the tissues. And that's what we're seeing here. That's what turns orange. All right, let's see, grabber. Now you got to understand, these herniations are not like the kind that you expect to see in the lower back. Huge, big herniations. These are smaller. And, you know, it doesn't require a big herniation to cause pain and suffering. Small herniations cause pain and suffering. Even more than big ones, a lot of times. All right, any other questions?
Yes, we have a comment leading up to a question from Big John on YouTube.
Uh-huh.
And they asked, Dr. D, just a follow-up to my last question at the end of the last surgery Q&A. I am only 5'8", and I'm an average-sized person living in a short person's world.
Understood, understood.
And Dr. Deuk, I uploaded my MRI on 9/11. Just wondering how far out you're running with scheduling telehealth appointments.
That's a great question.
I have to leave for an appointment right now. I'll catch your answer on the recording.
Yeah, sorry. Sam is the one to talk to. You can reach her at 321-775-1299. But if you submitted your MRI then, as long as we've got the images, then you should have your appointment like very soon, like this week, I would imagine. If you're not getting contacted, I would like to know. I have a whole team that's hired just to handle MRI reviews. That's all they're paid to do. So if there are people not getting their MRI reviews set up, I would want to know that. Normally they're very good. These two girls are amazing. So I don't know. I would call Sam though at 321-775-1299. We are almost done with the first disc. It has been incredible. Really, really, really degenerated. It has not been easy. I'm actually amazed we got the 7mm tube in there. I'm happy we did. Almost done here. Getting a little bit of epidural bleeding. I need the grabber. That's just a little epidural vein. You know, they're a nuisance. The amount of bleeding is minimal, but it makes visibility difficult. All right, let's see what we got. Yeah. I think we got everything we can get. I don't see anything more. That's all soft tissue around the cord. I think we're done. There's some calcified stuff there. All right. We're done here. So I'm happy with that. Pretty degenerated, but we're good. Got a good clean out. Keep the questions coming. I'm happy to answer them for you.
We do have another question.
One more irrigation. Is this clean? Is this open? Is this open? Come on, Luis, you got to be checking that. I'll take the next question.
Next question comes from, forgive me if I'm, this comes from Ram on YouTube.
Ram,
Ram, like the...
Oh, no, I don't want to talk to that guy.
Oh, I apologize.
Those guys are real... I don't know, I don't want to say it, but I've seen some of his comments. They're very not appreciated at all.
They have a good question, though.
Sure.
This first one comes, they ask, is this surgery a permanent fix, or is there any other chances to recurring the issue?
Yeah, so Ram, you're not welcome based on some of the comments you've made. I will answer your question because I think it's of value to other people. And basically, this surgery is a permanent fix unless the patient reherniates their disc. The chance of reherniation is 1%. So that means 1 out of every 100 of these surgery patients will reherniate. And that's usually because they're doing something they're not supposed to do. I have to say almost 100% of the reherniations, we've had 17 of them, have always been because they're not wearing their collar, they're not engaging in the restrictions they're supposed to, they're doing things they're not supposed to do. So we've had 17 reherniations over the years, 17 years. All right, let's get an x-ray. So there we go. Things are looking good. We just finished that disc at 7-8. We're going to move on to the 5-6. Let's get an AP view. Let me have a coker. All right, so we've taken one tube out, and I'm putting pressure here, right where we did the incision. It looks good. Let's see the lung fields.
Looks sharp.
Yeah, I see the pulmonary markings going all the way out to the inside of the rib. You want to show us that, Jordan? And where is the most common, oh no, all the way out to the rib, all the way out. There we go. Where is the most common for a place for pneumothorax? Apical, right? At the top. And I don't see anything up there. You got a nice marking. Show us the markings. Yeah, those little streaks, those gray streaks go all the way out to the inside of the rib. Show us the inside of the rib. There you go. All right? We call that the, what is that, the parietal pleura that lines the inside of the ribs? It's been a long time.
Visceral's on the lung.
Yeah, so it'd be the parietal pleura that lines the lung, the rib. And it looks good. So I don't see anything. All right? No bleeding. It looks perfect. I'm just going to put pressure because I need a, all right, so we already did the num-num. I'll make my second incision. She's still asleep.
Yes.
Okay. 7 millimeters. All right. Guide wire is in. Shot. All right. I got to see my guide wire. Shot. Now I talk out loud so that you all can hear what I'm thinking. After all, I'm here to teach you and do the surgery at the same time. Shot. So I like to talk out loud because it gives you a window into my brain. You can know what I'm thinking. Shot. As a matter of fact, when we're training as residents in neurosurgery and fellows, we're hoping our attendings will talk during the surgery so we can gain some insight and knowledge into what they're doing and why they're doing it. And that's why I talk to you, because that's how we learned. It's one thing to watch, shot. It's another thing to understand the thought of the operator and why they choose the decisions they're choosing, what they're looking for. That's the most helpful teaching I ever had. And I'll be honest with you, there was very little of it done. The vast majority of neurosurgery training for me and my colleagues was through observation. Our attendings didn't teach you like your first grade teacher taught you. They were more or less just quiet, operating, and you didn't really benefit in any way from like understanding their thoughts as they did things. So right now I'm twisting my dilator down. I'm looking at the x-ray. I could see the tip of the dilator is just outside the disc. I'm going to just tap it in gently, and I don't have much resistance at all, which is great. Because like I told you before, we have a choice in these cases to use the bigger equipment or the smaller. Okay, you see the second hole right there? See it?
Yes.
Second hole?
Yes, sir.
You want to be away from the second hole. That's the whole idea. That gives you a nice mid-shaft position of the impactor. You don't want to be doing it the other way. Shot? All right, so I am now right up against the back of the disc, and I've got to keep my eye on the dilator, the guide wire, the shaft, everything. I'm starting to enter the disc, and the beauty is that the guide wire will guide my dilator. It will help me, and Dr. Berndes is doing everything he can to relax the patient so that I can advance my equipment. Yeah, we've pinched the guide wire. Get rid of that one. Throw it away. Shot. So I pinched the guide wire at the tip. Okay, we're in. We are in, and we're in good. So I'm happy about that. Let me see. Let's go with an AP. It's always harder the further up you go because you're forced laterally. Yeah. We are. We've been forced laterally. We're going to have to reposition. Go back to a lateral. Shot? Yeah. We're just lateral, and I don't like that positioning. So let's go ahead and pull this back. I'm going to have to redirect. That's what was happening. We were getting forced by her facet joint laterally. Shot? All right, you're way off on orbit. Can you fix your orbit for me? Come on, Jordan. Do you see the back of the vertebral body 2 down? They're offset by like 5 degrees. That's better. That's definitely better. All right, so I'm going to pull back a little bit more. That's almost good. And I'm going to redirect medially at the back of the disc. Shot? Shot? It's as far back as I can pull, and I've got to go more medial. Shot? Yeah. Definitely can't go any deeper than that. I don't know. Let me see. I got to get an AP. I think we're in. It's forced me out again. It's forced me out again. All right. Here's what I want to do. Go back to a lateral. Let me have the remover. So I'm checking my AP view. I'm not happy with the position. We're too lateral. Something is pushing me laterally. We're just skiving the side of the disc, and I don't want to do that. So I'm going to try to do this by replacing our needle. By first our guide wire and then our needle. I think we're just a little bit too lateral on the disc. We're just not making it in. Shot. Now I could start over by replacing the needle, or I can bring this thing back right to the edge of the disc, which is where I am now. And you can see I'm reorienting it, but it keeps forcing me out. Give me the guide wire. Same one? Oh, a different one? All right, so I'm going to go into the back of the disc. Shot. 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 All right, I see. There it is. Shot. All right, I'm right at the back of her disc. Shot. Now I'm going to take my dilator out. I may have to just replace with the needle. Shot. Yeah. See, that little thing is there, the little EKG lead. And I think this is jam-packed with bone. Shot. Yep. We're going to have to try over again with just a new needle. See the bone there, Luis? You really got to clean that out when it comes out. All right, so we're going to try again with the needle. Lateral view, lateral view, lateral view. So what was happening was I was hitting the side of the disc, and there may be some bone spur or something there. It was literally forcing me to the side of the disc, and I didn't want to be on the side of the disc. So, shot. All right, so we're going to try that same disc again. At least we have dye in it. Gives us a target. Shot. 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 All right, there's bone. Shot. I've just got to get around it. See, that was the problem we had originally, was her facet and rib is pushing me laterally. All right, let's see where we are on an AP view. I'm going to have to try to be a little more aggressive, getting medial towards the center. Okay, that looks good. Back to a lateral. All right, so you see we're off just about a degree on orbit. Try orbit 1 degree. I think that's worse. Try the other direction instead. That's better. That's better. So that's good. All right, let's try to make this happen. Shot. Shot. Feels like herniation. Shot. Damn, that little lead right there. Can you get that? I guess there's no way to get it off, huh? That's your EKG lead. Give me an AP. You see the lead? No. You see the lead where the needle is?
Oh, yeah.
It's like literally in exactly the worst spot. All right, that looks really good. Huh? No, I'm there. I'm right on the interpedicular, midpedicular line, so I think we're off a little on the APs. Can you give me another AP? You see how your spinous processes are off to my side? You need to line those up a little better, Jordan. That should be automatic. You're off on rotation. Nope. Nope, worse. Come on, Jordan. There we go. That's good. All right, let's go back to a lateral. Looks perfect on the AP view. Let's go back to a lateral view. So this time I've come in at a more aggressive angle, lateral to medial, hoping to dive into the disc a little better. We'll see. There's something over here that's kind of forcing me laterally. Shot. I'm going to try to dig in and go medial. I feel better on that one. AP. So if I'm happy with my needle position, I'll place the guide wire, which will lock things in to that trajectory. That will give me the target that I need and the pathway I need. There we go. See how the tip of the needle is in the center now? Show us that, Jordan. The center is the line of spinous processes, and the tip of the needle is in the center of the disc. So we're in. At this point, and my technique worked, and now I'm going to put the guide wire back down, and this way the dilator should follow it right into the disc, to the center, in theory. All right, is that it? Shot? And shot? Yeah, so we're there. I'm taking my needle out, leaving the guide wire. You got that? So shot, give me an AP. So you see the guide wires there on the lateral view. We're going to check an AP view. And I expect to see the tip of the guide wire in the middle. There it is. It's in the middle. Beautiful. So that time it worked. Now we're going to go back and reset. And I will tell you, folks, the devil's in the details. The devil is in the details. Now I just need this dilator to do its job and follow the guide wire. Because I've got a nice safe path for this whole process, as long as the dilator does what it's supposed to do. Follow the guide wire. Now, you can see I'm a bit more aggressive. Shot. I'm at the back of the disc, and I'm a bit more aggressive in my angle going medially. It's closer to a 35-degree angle. So I'm going to pull lateral as I hammer in. Shot. And hopefully this time, you see there's a pinch between the dilator and the guide wire. I got to pull this back just a little bit. I don't want to advance the guide wire into the thoracic cavity. Shot. I'm definitely in the disc, so I'm just going to take the guide wire out. And again, it's bent it. Shot. And let's hope we've gone in as far as we can. Let's just hope we're there. AP, wait. AP. Something about her anatomy is just forcing me. Let's hope we're still in the middle. Damn it, it forced me wide again. That's incredible. I've never seen that happen. Something is literally forcing us wide. Well, I need to take that out. Lateral. Come on, Jordan. Yeah, that's not working. There's some kind of a bone or something pushing me laterally. That's where we are right now? I guess I could try one last time. I think that this is going to help, but I don't know how much it's going to help, because placing the dilator does reduce the herniation. Question is, how much will it help? I don't know. Shot. It's just so strange. Shot. I'm really going as medial as I can. Shot. All right. I don't know. Let's see. It's just, I feel it pushing me. It's not her. It's not her physiology, it's her anatomy. Something bony is pushing me lateral. Yeah, it did it again.
Maybe it's the way the rib takeoff is or something?
Could be the rib head.
The rib head, that's what I was thinking.
No.
It's not anything else. Could have some inflammation.
Lateral.
Right?
I mean, that's,
Bony overgrowth there?
huh?
Could have some bony overgrowth on the rib head.
No, there is some arthritis there. You can see it. Show us, Jordan.
This poor patient has had 18
Yeah.
car accidents.
18 car accidents? Well, I've tried everything I can do. I'm not sure what else I can do. I mean, if I keep messing around, we could end up with a... No. No, we're in the perfect trajectory. It's a perfect trajectory. Like, literally, you can't do better than that. It's not like changing my trajectory can fix this. Something right at the back of the disc is pushing us.
'Cause I saw you trying to move the medial too when you were
I tried. I pulled hard.
Right.
I mean, there's only so much you can do. Safely, that is. Shot?
Put some local.
Hmm?
I was thinking maybe put a little bit of steroid there too.
No, I'm going to do that, but I want to make absolutely sure. Look at the angle there, and it's just something is forcing me up as I go in. It's really pushing the tip laterally. It's really what's happening. You know what I can do? Cervical. Give me the guide wire. Shot. 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 AP. That should be in the disc. Just quick AP. Come on, Jordan. Doesn't need to be. Lateral. Yeah. We were better off with shot. We were better off with the needle guiding it. Let's try one more time. Shot. Shot. AP. See if that worked. So I'm using my dilator as a guide to guide the guide wire in. Shot. It's better. I'm going to take this out, and I'm going to try the cervical, a smaller scope. I don't know if it's going to work, but we're going to try. This is really the last thing I can do. Shot. Okay. Shot. So I'm right at the back. Man. Again, it's sliding outside. Shot. Let's give me an AP. Take. Just a quick shot. All right, that looks good. Give me a lateral. So I'm trying a smaller system, which might work. If you're here for her, I would be praying right now. Let's see if we can get this to work. Shot. Shot. Let's get an AP and see where we are. Yeah, it did it again. Well, I can go in with the scope at least right here, and I can clean up that area. Let's go ahead and do that. At least we're inside the disc. We're just in the corner. I think we're good. Give me the tube, please. All right, impactor. So we're going to proceed with the smaller scope. Impactor. No. Shot. Shot. Yeah, I can feel the disc is collapsed. Shot. Uh-huh. Let's go AP. Nope. Should be good. Yep. It's as good as we're going to get it. Thank you. All right. Well, we salvaged that. Wasn't what I was hoping for in terms of the bigger scope, but it is definitely good that we were able to get this in. You want to work on that, closing that one? We got 10 minutes left, Doctor.
She's doing well.
Good. I'm very happy to hear she's well. Alrighty then. So we're inside the T5-6 disc. All right, Henry, do you have any questions?
Yes, we have a question from Allison on YouTube.
Okay, I just want to make a statement that, you know, you guys watch our surgeries. We do everything live. We do it live for many reasons. One is we want everyone to see the truth. You know, spine surgery is not easy all the time. There are struggles. And, you know, really how your surgeon handles the struggles is very important. A lot of surgeons fail under pressure, fail miserably. When they fail the patient, they fail themselves, they fail the family, they fail everyone. But, you know, failure is part of life. Every one of us fails. I'm not perfect by any means. I failed too. Had a lot of failures to get here. But the important thing is, as a surgeon, when you're going to fail, try to fail in a way that doesn't harm the patient and preserves safety of the patient as much as you can.
Here, I agree to that.
Yeah. And, you know, learn when you've been defeated. Learn to recognize it. Learn to accept it. Don't let your ego get in the way. I was ready to stop after this, but thank God we were able to get in and repair this disc. Albeit with a smaller scope, which is fine. That's how we used to do thoracics anyway, smaller scope. It wasn't until recently that I started using a bigger scope. You know, in surgery, sometimes you cannot achieve all your goals that you set out to achieve. And you have to learn to accept that. You do your best, but in the end, you have to always make decisions. What's best for the patient? And that should always be first and foremost in your mind. What's best for the patient while you're in there? Don't try to be a hero. Just do what you know you can achieve and accomplish safely. And you're going to get out of your comfort zone at times, and you have to be ready for that. Mentally, physically, equipment, staff, drugs, support, everything has to be ready for being outside your comfort zone. Because inevitably, you're going to find yourself there as a surgeon or a doctor in treating a patient. And you can't just cower and run away, head for the hills. Your patient needs you to do your best, to respond, you know, to perform. And so that's what we try to do, our very best, every single time. And if you run and hide, then who's going to be there for the patient? That's really what it comes down to. So the patient needs you. They need you there. So don't run. In the end, no one practices perfect medicine. No one. No one has a perfect record. no doctor. But you can't be afraid of failure, because it's your fear of failure that will drive you to make the wrong decisions and choices. And you have to live with them. And you never will be able to, because you'll know you ran away instead of facing the monsters. I talked one time about video games and how important they were in my life. One thing about video games is you can't go past the level you're on to the harder levels, the better levels, until you defeat the level boss, the monster at the end of the level. And it's a really hard monster to defeat. But once you've defeated it, you've learned something new. You've gained something. It's made you a better player. And in life, it's the same thing. You're going to encounter challenges they seem insurmountable. But you can't give up. You have to face them. And you're going to find that those challenges, many times you'll be able to overcome them as long as you are focused and you have a sound mind, you develop a strategy, and you stick to it. You can actually overcome those challenges. So surgery is no different. You have to be ready to fight monsters that pop their heads up. All right, just about done. 5 minutes, doctor. 5 minutes or less. I will take questions. I may want to answer them when I'm done. I could take a few right now while I'm working on this.
One. This next question comes from Allison on YouTube.
All right, Allison, welcome to our stream.
They ask, is all of that dark stuff, the dye coloring, the deadened disc material?
Yes, the blue stuff is the degenerated nucleus pulposus, basically the herniation. And this stuff here is scar tissue, okay, we're dealing with. We're inside the disc, and we're in the wall of the disc called the annular tear. This is where all the pain comes from. And you can see this white stuff. I'm going to go grab some of it out because it's too big to laser it. That's all scar tissue from chronic inflammation. There's a piece right there. You can see it? Oh, yeah. All right. Okay, we got 2 minutes left. We'll be done. I'm almost finished here. How's she doing?
Great.
Good. Yep. Yeah, she hasn't made it easy, that's for sure. But switching scopes to the smaller scope has helped. This should be the last of the herniation. And I keep pulling my scope out because I'm trying to float out these pieces of herniation. That's how we get rid of them. We float them up and out. There's a constant flow of water, not really water, but saline. I call it water, but it's mostly water, obviously. Saline solution that is really physiologically pH and electrolytes and all that stuff. So good news is we are in the herniation. And maybe the disc space just kept rejecting us because it's just her anatomy. That's not something I can fix, you know. But the good news is we're getting the job done, and I'm happy about that. All right, any other questions? All right. So we're going to ask a few more questions in a moment. Get your questions typed up. I'm going to come and answer them face to face with you, the audience. And I'm really happy we stuck it out. I talk about monsters and levels and stuff, but in the end, the monsters are just the challenges we're faced with every day in life, all of us. And we have to deal with them. And thank God we have the ability to do that properly. So we're done. Everything went good. I'm happy. You can see the whole surgery was done with 2 tiny incisions, 7 millimeters and 7 millimeters. We're cleaning out the antiseptic. Yeah, that should be good. We're going to put a staple, and we'll get those out tomorrow when the patient comes to clinic. Great job, everybody. Tough, tough, tough case. But the nice thing is we overcame a very difficult challenge, one that I haven't had in the thoracic before. I've had it in the lumbar, but this is the first time in the thoracic. So it went really well. In the end, we stuck it out and got it done. Alrighty then. Our EBO was probably around 5 cc's max. We'll call it 5. Can you guys see these incisions?
Yes, we do.
So we'll get those closed up nicely in a moment. I'm putting a little pressure on the muscle. I want to make sure we don't get any blood in the muscle. When you get blood in the muscle, it causes a pain that kind of sits in the muscles for months after the surgery. I try to avoid it at all costs. A lot of times it has to do with the blood pressure of the patient. We do our best to keep the blood pressure low. It's perfect where it is for her. And you can actually feel the muscle with your fingers at the end, and I don't feel any blood clot at all. You got everything? Thank you, Luis. Thanks, everybody. I'll come and answer your questions. Type them up. Thanks for joining us and sticking it out. Good morning, I'm Dr. Deuk at the Deuk Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Deuk laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day. Great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or two sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7mm 1/4" incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Deuk laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my back.
Yes, when I walked in and saw him this morning for the first time, the first thing your mother said was, "Look how straight he's standing." So they must have watched you suffer for a long time.
Oh yeah, yeah. Yeah, my mom's a great lady. I'm blessed to have her in my life. And then that's my stepfather, Jerry. He's a wonderful man. He and I are pilots. We fly together. We do a lot of things. And he's seen me go downhill. He knew something was wrong, you know.
How did you find out about us?
I've been seeing a chiropractor in Sacramento for 35 years. And 2 months ago, I started to really feel bad. And I would go to him. And after about a month of going to him and going to my doctor for some pain management for these symptoms, I finally figured out that something else was wrong with me. And so I asked the chiropractor, what can we do, because what you're doing is not helping me. My doctor put me on pain meds, and they took some of the sharp pain away, but nothing was helping. And so, being kind of a mechanical engineer, I decided to look into how my back was put together. And I requested an MRI from my doctor and from my chiropractor. And so that took 3 weeks to schedule. That's a long story. And I finally got an MRI, and I looked at it myself and realized that I had a cyst of some sort and that I had some problems with my lower discs. And that's when my chiropractor told me about you. He said, get on the internet and do some research and then call these people. So I called your store. They gave me some information. I FedExed my package to you guys, and a week later you called me. And about a week or two later, I got here.
Wonderful.
So, yeah.
And here you are pain-free for the first time in many years.
Many years, many years.
Congratulations.
Yeah. Thank you.
Is there anything you want to say to your fans out there?
There is. This is a miracle. In Sacramento, everybody that I know said, why are you going? Why are you going to Florida? Why don't you find somebody in Sacramento? And I said, well, because I was referred to Dr. Deuk and I've done a bunch of research on him, and I just have a great feeling about him. Not only that, he personally called me on the telephone because I told his people that I had some questions. And that's what sealed the deal. And so it took a while to get here, but it was worth everything. And I would recommend anybody send your MRI to this guy, and if he can help you, he will. Okay? Thank you, Doc.
You're welcome, sir. It's my pleasure.
Yeah, absolutely.
All right, go enjoy the rest of your
All right,
life.
thank you.
And welcome. Yep, thanks for watching. I'm Dr. Deuk, and we just completed our thoracic Deuk laser disc repair. The patient had herniated discs, 5 of them in her back, in her thoracic spine, and we went after the 2 that we believe are causing the most pain. That was the patient's choice to treat 2 instead of 5. But as you could see from the surgery, the first disc we fixed went just fine. And just so you understand where we're coming from the side, we're coming in, we're going just past the facet and getting into the herniated disc this way. It's called transforaminal. We're going across the foramen, which is this opening here. Now, when I got to the upper disc, because the anatomy of her spine, I was trying to get in, and every time I was aiming towards medial, towards this disc, something here was pushing me lateral to the side. Okay, that's what was happening. And in the end, I ended up having to go with a smaller tube, and it worked fine. I would have rather had a larger tube, but in the end, we tried and we couldn't do it. So it was either give up and not do anything or go with the smaller one. Now the smaller one is the one we did our first thoracic surgeries with, and it worked just fine. But I do like the bigger tube when I can get in there. All right, in the end we got everything done. I think the patient did well. We lost very, very little blood, maybe 5 cc's at most. And 5 cc's is like 5 times 20, 100 drops of blood. It's not too much at all. Patient will spend an hour recovering, and then she gets to go back to her hotel. She's from California. They'll fly home tomorrow. These surgeries you're watching are outpatient. We don't do any inpatient surgery. There's no need for it. Doing surgery at the hospital is riskier. Surgeries at the hospital are always more dangerous, more invasive, higher chance of complications. These surgeries are wonderful, very low complication rate, less than 1 per 1,000. Okay, let's do our questions.
All right, these next 3 questions all come from Allison on YouTube.
All right, Allison, getting your questions in.
This first one asks, does scar tissue from a long-term herniation get addressed with this?
That's a great question, Allison. So she's asking, does scar tissue from a chronic herniation get addressed? Absolutely. You see the scar tissue is the white stuff, and it's got little calcium flecks. All day long, I'm in there zapping it away with the laser. No problem. We get rid of scar tissue.
Next question is, does scar tissue ever get stuck to the nerve?
Does scar tissue ever get stuck to the nerve? Absolutely, scar tissue gets stuck to the nerve. Yes, it does. As a matter of fact, if you have a lot of scar tissue from prior surgery, for example, the kind of surgeries that cause scar tissue to stick to your nerve are laminectomy, discectomy, microdiscectomy, fusions, foraminotomies, any of those open invasive surgeries where the surgeon is removing bone, even ultrasonic surgery, same thing. You're going to get bleeding, you're going to get scar tissue sticking to the nerve, but not with the Deuk laser disc repair.
And lastly, she asked, if you keep penetrating the disc to get a better angle, does that compromise that wall of the disc?
That's a great question. You are asking amazing questions. Please come every surgery. I love your questions. So you keep penetrating the disc. Does that compromise the wall? Let's take a look at the wall. So this is the wall of the disc. It's called the annulus fibrosus. And it turns out that where we're trying to go in, the wall is exactly where the wall is already torn up. And that's where the herniation is. So I kept going in through the tear that was already there. So the answer is no. We are not compromising the wall. The beauty of our surgery is we're going into the disc right where the wall is already busted open.
And that is it for questions.
What?
Yeah.
All right, come on, guys and gals.
Allison just added, I talked to you on the phone on Friday, had a lot of questions then. If you can fix me, I'll come work with you.
Awesome.
Yeah.
Well, Allison, thank you for sharing. Great questions you had today. We have one more surgery. It's our last one. And today is a very special day for a lot of reasons. Number one, I have a new hat, in case you didn't notice. This is the Deuk Joint Institute hat. Why are we having a Deuk Joint Institute? It's our sister company, and we treat knee, hip, and shoulder pain, sacroiliac joint pain as well. We treat it with a new technology called plasma rhizotomy. And this was developed here at Deuk Spine because so many people would have a rhizotomy with a radiofrequency ablation, RFA rhizotomy, and their pain just doesn't go away. It keeps coming back, keeps coming back. So we figured out a way to make it so the pain never comes back. We call it the Deuk plasma rhizotomy. And that's where we go in and burn the pain nerves with a much more powerful energy source, and we're able to move it around while we're burning. Very different than an RFA. We've been doing it now for a year. We've had great results, about 85% on the first couple of patients with hips, knees, 85% of their chronic pain gone. And these are people who were told they had to have a hip replacement or a knee replacement. And that is not the case anymore. We're now treating it with 3mm incisions with outpatient. So consider us for those problems. The other reason today is such an amazing day is because we're doing the 3 types of spine surgery all in one day, back to back, starting with the cervical this morning, thoracic we just finished, lumbar is next. Our patient for the cervical was from
I got it.
Michigan.
Yeah.
Michigan. Second patient with the thoracic is from California, and our last patient is from Nevada.
Yeah.
Actually, our last patient works in the casinos in Las Vegas and has traveled here, unfortunately, after having botched surgery elsewhere. I don't want to say too much, but he talked to me a few years ago and decided to go to a different surgeon because the other surgeon was cheaper, and he's here now having the surgery he should have had a few years ago, but now he's got scar tissue and his spine is all tore up from the prior surgery. We'll get into that more in the next surgery, but I'm glad he's here. I'm glad he made the right choice. We're going to help him out. We're going to get him better.
We do have one more question.
All right, we got a question, no problem.
This comes from Allison once more on YouTube.
You're on fire, Allison.
And she asks, how about if you're doing a neck surgery and have to penetrate the front wall multiple times to get to the back where the rubble is? Does that compromise?
What if we're doing, so she's saying, now let's do a cervical disc, okay, in your neck, and you got to pass through the front wall to get to the back. And you got to puncture the front several times. First of all, we never puncture the front several times, but let's pretend we did just for your discussion. Allison, the thing a lot of people don't understand is this front wall and even the back wall is fibrous, just like the clothing you're wearing right now, assuming you're wearing clothing, unless you're not wearing any clothing while you watch our live streams, which would be quite interesting. But that said, it's like clothing, okay? When you take a pen and you push the pen through your blouse to lock it onto your blouse, that little needle-like tip, it doesn't cut your material of your dress, it spreads the fibers apart. So when it goes in, it literally pushes them apart, and when you come out, it comes back together. You're not damaging your dress at all. You're just spreading the fibers. If you look carefully at those fibers, you'll see they're bent to the side and then they come back. So that's exactly what we do when we're going through the front of your disc. The dilator going through the front of the disc is not cutting anything, it's spreading it. So it doesn't matter if you go through it 5 times, 1 time, 10 times, you're not damaging the disc at all.
And then one more just added. This comes from, forgive me, I can't pronounce the first name. The last name is Mahone.
Okay, forgive me, I can't pronounce the name. The last name is Mahone. Nice to meet you.
They asked Dr. Deuk, do you accept patients from outside the U.S.?
We do take patients from outside the United States. About 10 to 15% of our current patients come from outside the United States, from other countries. We don't discriminate against anybody. We want to take every person suffering and fix every one of them. If we could do that, we would. We're actually opening an office in Orlando, Florida very soon, right next to the airport, so that we can service patients that fly into Orlando Airport, get their surgeries done, and then they can go home. So it's going to be really wonderful being part of that Orlando community. Many of you know that I'm a professor at the medical school in Orlando in neurosurgery. I'm a neurosurgery professor, and I teach the medical students there at the University of Central Florida School of Medicine. I've been a volunteer professor, faculty there since they opened the school. I can't remember when that was. It was around 2009. So it's going on 15, 16 years now. I love teaching, and I love to be part of the medical community. So yes, we don't have any facilities overseas yet. Someday we will. I'm going to leave that for my son to do, Arias. He will pick this up and take over someday and help expand Deuk Spine Institute and Deuk Joint Institute all over the world. So thanks for joining us. We'll see you in 45 minutes for our last case.